I'm Dr. Aman Ismail from USM. I'll be discussing gynae asymmetry, simple, straightforward urogyney case. A 58-year-old lady with a stress urinary incontinence, and discuss your management. Of my presentation, first I'll go your overall performance. Second, we go to market scheme, and then common mistakes you make, and then lastly conclusion. I'm sure you are exhausted and hungry now. It's 12 o'clock already, but I hope you are all not saturated yet. Please bear with me for next 20 minutes. As this is quite important topics. Urogynys definitely come every exam. At least one question for your essay. So overall, your performance not so encouraging. 30% of you did okay, 70% not okay. So I've been wondering why is it so? I think maybe because of the lack of reduced urogyney service for the past 1 or 2 years because of COVID. I think my institution also, I cut down my urogyney for nearly 80 to 90% of urogyney cases because of it is considered non-essential and can be postponed at the moment to give priority to COVID. And then marks given out of 20, see quite wide range from 6 out of 20 to 18. So surely some of you are quite well versed with this topic, and some of you still in the cloud. And still common old mistake made by quite a number of you all. But good thing is that your handling all are settled. So marking scheme, 58 years old presented with stress urinary incontinence, discuss your management. So 58 years old means she's menopause already. She's menopause. So it's very important, as in the management, certain issues might arise such as hypoestrogenization. And because of that, Primarine cream or estrogen is indicated. And then stress urinary incontinence, I underlined here. So, and the second keyword. So here diagnosis is given, stress urinary incontinence. You don't have to exclude other causes of incontinence. If it is given urinary incontinence, then of course you have to exclude urge incontinence whatsoever. This one clearly stated stress urinary incontinence. This is straightforward. You don't have to exclude other causes of urinary incontinence. The keyword is discussed. The worst is justified. Discuss is quite straightforward. In your history examination investigation, if discuss, you just say what you want to do and why. For example, I would like to inquire about diuretics intake as it worsen the stress incontinence. That's all. As far as treatment is concerned, if you discuss, you said first line treatment is pelvic floor exercise. I do it 8 contractions 3 times a day for at least 3 months. That's all. You don't have to justify. You don't have to discuss the advantages, disadvantages of pelvic floor exercise and so on. Just describe it. Yeah. The third part is management. I'm quite upset to see, despite repeated message, a reminder to all of you, still many of you still don't understand this word management. As previous speaker has told you, management comprises of 4 parts: history, examination, investigation, and treatment. Surprisingly few of you, quite a good candidate, very knowledgeable, straight away went to treatment. And if you can see here, the allocation of marks, even you are excellent, full of knowledge, if you go straight, you still fail the essay. I think 3 of you did very well, got 7 or 8 full marks, but only go straight to treatment. So you fail this question. And then the other one, quite a number of you with superficial knowledge, a bit here and there, still don't know where to go. Got 2 history, 2 examination, investigation got 1, and then treatment got 4, and still pass the exam. So very important to understand what the question was. And lastly, global, I give 1 mark. This is to see your flow of thinking and the outline of your essay with a good introduction, body, and conclusion. I give you 1 mark for that. And then history, 4 marks. Okay. The things that you should know, the first and foremost is of course the severity. You ask about the leaking episode, how many leaking episodes per day, and then you ask about event that leads to leaking. For example, sneezing and coughing. This is for not so the mild one. And if it's more severe, it leaks on climbing stairs or lifting. And if it's very severe one, patient leaks even with changing position. For example, from sitting to standing, from standing to sitting, and vice versa. And then you must ask about quality of life. Urogyne is not very rarely life-threatening, but it's about quality of life. So quality of life is very important. Ask about how does it affect her working daily routine and sex. Right? And aggravating factors must be as chronic cough, constipation, diuretics, prolapse, because you successfully. So ask about obstetric history. These are risk factors for prolapse, for incontinence like multi-parity instrumentation, prolonged labor. And don't forget about treatment history, like previous continence surgery, because this treatment history affect whatever treatment that you would like to offer to the patient now. And out of 4 marks, I give you 1 here, severity, 1 quality of life, and aggravating factors 1, and these last 2 I give half each. Now, as I mentioned, I have 4 marks here. In general, we look for obesity, because in obesity there will be increased intra-abdominal pressure, and it will worsen the stress incontinence. It's very important. And respiratory, you look for, again, condition that increase intra-abdominal pressure in those with chronic obstructive airway diseases. And neurological is not so important, but I give you half mark if you write this. You look for nerve root of S234, because this is S234 is the one that innervates the bladder, as well as the nerve root for the pudendal nerve, which is the main nerve for the pelvic, for the perineum. Just do perineal sensation and anal reflex will be suffice. And abdominal examination, you should look for mass, as mass will give a pressure effect and cause incontinence. And pelvic examination, very important to look for as evidence of hypoestrogenization, such as sparse pubic hair, very thin, pale vagina, because you need to treat them. And then perineal exploration, because of urine irritation, prolapse and cystosis, as this can cause incontinence. And demonstrate incontinence to confirm the incontinence. Ask patient to cough and see the incontinence. And again, by manual and also by manual examination to look for concomitant pelvic mass. So I give 4 marks here, maybe half mark each. And investigation carries 3 marks. The most important is urine FAME and CNS, plus or minus CNS. This is because urine infection can present with urine incontinence. You have to rule out, these 2 things must be ruled out. Diabetes also can present with urine incontinence. And the third one, bladder diary or frequency volume charts, not so important, more important in urgency incontinence, but it helps to do bladder diary. For example, you can know whether the patient is taking too much fluid or not, which will worsen the incontinence. And you want to do ultrasound, look for any mass, upper abdomen, mass effect. And I put here in bracket, this one is for urge incontinence, for residual urine, but not for stress incontinence. And others, urodynamic. Even though it's not routinely done, you must state that it is not routinely done. I give you 1 mark for this, because urodynamic is such a synonym investigation in urogyne. Even though it's not done, you must say that it's not done routinely. And only prior to surgical intervention. So it's very important you not to just 1 or 2. In essay, test the breadth, the width of your knowledge. We want to include everything, but not so deep into everything, but we want to see the scope of the answer. It must be broader. You aim to give a broad point, encompasses almost everything. So treatment is where the main marks lies, 8 marks. So the first one, of course, behavioral. Fluid intake should be limited or reduced 1.5 liters per day. Reduce weight to reduce the intra-abdominal pressure, and of course, stop smoking. And then first line of treatment is pelvic floor exercise. Many of you just said pelvic floor exercise. It's just like saying, I'll prescribe antibiotics. It doesn't, I won't give you marks if you just say I will prescribe antibiotic. You must say what antibiotic you want to give and how much. The same thing here. You just say pelvic floor exercise, I will not give you marks because such important thing. Just prescribe for so many regime of pelvic floor exercise, any regime I will accept. So the easiest one is the one that given by NICE UK, 8 contraction 3 times a day, minimum for 3 months. Others also I will accept as long as you prescribe in detail what constitute pelvic floor exercise. This is minimum. Of course, it's as long as patient muscle strength increases, you should increase the contraction from 8 to 12 and so on. So adjunct treatment not routinely offered, like biofeedback, is good to mention. I give you marks, but you must know the rule. Biofeedback is those who are not so motivated. Give them motivation. If they contract the pelvic floor muscle, they can see the meter go up, something like that. It motivates them to see that. And vaginal colon do pelvic floor exercise on their own. Those who cannot find the muscle, the correct muscle to contract. And treatment, surgical is failed conservative management. I mean, fail pelvic floor exercise mainly. So mid-ureter tape, which can be done retropubic or transobturated tape. Continence rate, you don't have to write that this is 90%. As long as you know it's excellent, continence rate is good. And it is made of treatment in Malaysia or Asia. Mind you, is in Europe, in US, the mid-ureter tape is use of mid-ureter tape is slowly fading off because of fear of erosion. But in Malaysia, in Asia, we are not at erosion and litigation. In Malaysia, in Asia, generally we are still okay with it, and this is still a main treatment. And because of this tape erosion issues, autologous fascia sling using rectus fascia, for example, is coming into picture nowadays. So another one that is make a comeback is Birch Copper suspension, also because of fear of the tape erosion. Birch Copper suspension can be done either open or laparoscopic. Excellent continence rates, comparable to me. Aphail, urethral tape, Birch, and autologous fascia sling. And medical, there's a medical called duloxetine, SSRI. It is for those who are not fit for surgery or refuse surgery. Fail conservative treatment and refuse surgery, you can use duloxetine. The continence rate is low, 50–60%, but the use is quite limited because of quite bad side effect, nausea and vomiting only. So you use limited because of side effect and low success rate. And lastly, surgical treatment is artificial sphincter as a last resort. This is the last resort because it's such an invasive surgery. But again, you see, we want to test the width of your knowledge. Of course, the most of the time you'll do mid-ureter, that's it. But in essay, you want to test the width of your knowledge. You must explore every possible option available, and with a bit of description of it only. Right? And then treatment, others which I'll give mark, also incontinent pessary. Those with prolapse and those incontinence associated with prolapse, and it has lower success rate compared to surgery. So those with prolapse and fails and doesn't want surgery, you can try this. And of course, estrogen cream for vaginal application. In this patient is beneficial because she's already in menopausal state. Improved symptom associated with vaginal atrophy is this. And common mistake that you are made, straight go to the treatment. I'm very upset to see at least 3 of you straight go to the treatment. Sure, fail one. And the sad part, those who went straight to treatment, they are good one. They are full of knowledge. I'm sure they'll get 18 marks if they answer correctly. So sure, fail one if you answer straight to treatment. What a waste. And history still want to differentiate types of incontinence. In this case, I told you don't have to differentiate type of incontinence. Type of incontinence basically for you all are 3, urge, stress, or mixed. In this case, you don't given stress urinary incontinence. No need to differentiate. That means you don't have to ask about frequency, nocturia, urgency, those associated with urge incontinence. And mix up stress with urge incontinence a lot. Many of you don't understand, still miss out stress and urge incontinence. Basically, stress is a structural problem, is a support problem. Weakness of pelvic floor muscle, weakness of muscle supporting the urethra, weakness of structure, muscle, fascia supporting the bladder. Why? So it's two different pathology. That's why even in this case, there are people asking about caffeine intake. This is caffeine, this for urge incontinence. It stimulates the bladder. And then examination, common mistake, like very superficial. You don't get marked by saying thorough head to toe examination without further explanation. This is out of idea statement. We don't give mark. You must say that what you want to look for, obesity, blah, 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 because increase in abdominal pressure and so on. And you miss simple thing like obesity, lung condition, those that increase in abdominal pressure. I give high marks for this, one each, even though it looks so simple, because it has got a big contribution on the management and treatment later on. And investigation, also perform appropriate investigation. It's really irritating to see people, quite a few writing like this. What perform appropriate investigation? Say, I cannot give you mark if you say this. I want to do urinary FAMD because urinary tract infection present like stress incontinence. That's all. Don't say this. I might minus mark in the real exam. Urodynamics, even though it's not done routinely, you must state that it's not done routinely and it's done in specific cases, right? So treatment, pelvic floor exercise, no detail. You just quote at least, no detail, just say pelvic floor exercise. No, you must quote at least one regime. Please quote the simplest, the nice regime that I quoted just now. And mix up with urge incontinence. For example, treatment, many of you would like to do Botox, neuromodulation, bladder training. These are for urge incontinence, not for stress incontinence, because this is for wiring issues, not structural issues. And describing the surgical procedure. Oh my God, you waste a lot of time by describing what mid-urethral tape all about. You don't describe the procedure. Mid-urethral tape is you support the mid-urethra and go out to the obturator, blah blah, to support this, blah blah. You don't describe only if you ask surgical treatment of stress incontinence. Then if we ask you surgical treatment, then you go into detail. What is the procedure and what are advantage, disadvantage of that procedure and how it is done. Otherwise, you don't do that. You don't say that. Waste your time and you don't get marks for that. And general introduction, of course, you should have introduction, and any reasonable description of the condition is acceptable. For example, you can say chronic debilitating stress incontinence, chronic debilitating disorder affecting quality of life. That's reasonable. But simple thing is that you give definition. If the question has definition, you give definition. Like this case is stress incontinence. Just give definition. It is involuntary loss of urine during increase in intra-abdominal pressure or during cough or sneezing. That's a good introduction already. Even better, we said is debilitating disorder, chronic debilitating disorders affecting quality of life. Paragraphing. Oh my God, you are right. Some of you so kedekut, it doesn't cost you anything by making paragraph. It helps us a lot as examiner to mark. At least you should have 4 separate paragraphs. History 1 paragraph, examination 1 paragraph, investigation 1 paragraph, treatment another paragraph. The more the better. In this essay context, maybe history should have 3 or 4 paragraphs, examination maybe 2, 3 paragraphs, investigation another 2, treatment maybe 4 or 5 paragraphs. So you should separate your point. My goodness. Some of you just mix history, examination, and investigation. Some of you give just 1 paragraph. My goodness, everything in 1 paragraph. That is so not so smart, because we will miss point. Basically, 1.1 if I would do 1.1 paragraph. We won't penalize you if you do a lot of paragraph. In fact, it helps us in correcting your essays. Short and sweet sentences, please. Usually 1 point explained in 1 to 3 sentences. For example, surgical treatment. Main surgical treatment nowadays is mid-uterine rape. It can be done by transobturator or retroperitoneal route. It has an excellent continuation rate 1 year. That's all. 1 paragraph. Move to the other one. I happily put 1 mark there. That's a perfect 1 mark sentence. So conclusion, few of you are already exam ready, so keep up the good work. But most of you need improvement, so you need to step up your effort. But I'm telling you, it's not too late. It's ample of time for you to improve. Ample of time. And so thank you for your attention. All the best in your coming exam. I welcome any question if you have time. Yeah. Thank you.
All right, thank you very much, Prof. Thank you very much, Dr. Ahmad Amin. So we have one question from the chat box. Each question lists, if the question lists down the treatment option, can we straight answer on management?
Okay, number one, we will never ask list the treatment option, because list means you put 1, 2, 3, 4, 5. List will be asked in OSCE. You should be clear of. List we only ask in OSCE 1, 2, 3, 4. So if you want the question list the treatment option, if you want to ask specifically treatment, we will say describe the treatment option of this patient. That's possible to come. That means you have to discuss mid-uterine rape, and then you tell what advantage, disadvantage of that tip. And then you ask urethral injection urethral bulking agent, advantages and disadvantages. Okay, list will never ask in theory exam, essay exam. I hope I answered the question. Any other question?
All right, there is no more question for Dr. Ami. Thank you, everyone. So, in view of the short time, we shall move on to our lunch talk. If you have any question, you can type it on the chat box so that we can direct it to any examiner involved. All right, so we'll move to our first lunch talk, navigating medical management of endometriosis, patient profile by Associate Prof. Dr. Ng BK. The floor is yours, Prof.
Thank you, Rowaida. I have do the recording for my lunch talk. Sean, can you help to play the lunch talk? I'll address your question in the chat.
Very good afternoon, everyone. I'm Dr. Ng here from UK Medical Center. Thank you for your support joining Part 2 MOG course. Of course, thanks to the sponsor so that we can lower down the registration fees. Today, I'm going to share with you the first lunch talk sponsored by Bayer, Navigating Medical Management of Endometriosis, Patient Profile. I have no conflict or interest and nothing to declare except receiving speaker honor name for this education talk. So what happened to the patient endometriosis during this pandemic COVID-19? An online survey was conducted by Turkish Endometriosis and Adenomyosis Society among 261 endometriosis patients. 83% of them afraid of endometriosis-related problem during pandemic. 54% thought their management was affected. 10% of their surgery was postponed. Another electronic survey was emailed between April and June 2020 to couples whose IVF treatment has been interrupted or postponed due to the COVID-19 pandemic. There were 308 females and 216 male participants. There were 45% of women and 31% of men show some anxiety or depression symptom. This is more significant if women more than 35 years old and had a previous IVF failure attempt. If we focus on symptom severity of anxiety, there were 11% patients had mild symptoms, 10% with moderate symptoms, and 0.6% experienced severe anxiety symptoms. Whereas symptoms of depression was 5% mild, 12% moderate, and 0.1% severe, we conclude that the psychological impacts of COVID-19 pandemic on the infertile couple who should have undergone IVF treatment has been significant. Thus, the topic sharing today is very relevant. Patients with endometriosis are not considered among the COVID-19 high-risk group unless those with history of collapsed lungs, lung resections, or had cardiothoracic surgery due to thoracic endometriosis. About 70% patients with endometriosis reported a negative impact of quality of life. 50% of their sexual life got affected. Work performance, housekeeping, and attendance at work were some of the areas involved as well. Endometriosis is a chronic condition affecting 5 to 10% of women of reproductive age. There are approximately 190 million women worldwide with this disease. Endometriosis is a benign chronic estrogen-dependent inflammatory condition where the endometrial-like mucosa spreads outside the uterus, predominantly in the pelvis area. These are the molecular pathogenesis that involve in endometriosis. Although many postulated theory, we must admit that the pathogenesis of endometriosis is still poorly understood. Perhaps these are the clinical manifestations that we see. The lesion could be found at the pelvic area, bowel, bladder, POD, pelvic side wall, and even at the rarer distant site like in the lungs or umbilicus. 3 types of endometriosis are there: ovarian endometrioma, superficial peritoneal implant, and lastly, treating endometriosis, which we knew that pain is a leading symptom of endometriosis. Patients with endometriosis classically presented with dysmenorrhea, dyspareunia, and subfertility issue. Due to the complexity and ambiguity of the symptom, a delay in diagnosis is common and may be as long as 7 to 10 years. The delay in diagnosis and the severity of pain-related symptoms cause considerable physical, psychologically, and social burden on the patient's life. Not surprisingly, they saw a few primary care visits before ended up with specialist level. Delay likely due to the non-specific symptom of women, they might just think that this is a normal period pain or primary dysmenorrhea. This is probably what happened to them when the woman has endometriosis. After delay of diagnosis, they probably end up with an emergency surgery followed by some medical suppression therapy and then another surgery because of recurrent. They got married and might have infertility issue, need assistance, then again on some form of medical therapy. Unfortunately, there's no permanent cure for endometriosis. Aims of endometriosis treatment is to alleviate pain, maintain or restore fertility, reduce lesions, prevent recurrence, improve quality of life if possible. We stick to the concept of one surgery and the last surgery for any endometriosis patient, maximize medical therapy and avoid multiple surgery. If we can demonstrate the case scenario to you, let's see what happened to Madam T. Madam T, 21-year-old single, nulliparous, presented with dysmenorrhea for the past 3 years and the pain got worse last 3 months. She needed to take analgesia during menses and frequently absent from work. Coming to managing any case, we shall always stick to some basic principle. In managing endometriosis, we should always diagnose and treat early, counsel patient regarding the need for lifelong management plan, again maximize medical therapy and minimize surgery, prevent and treat recurrence, and lastly, maintain the long-term therapy. Endometriosis is frequently misdiagnosed with other causes for abdominal pain. Not to our surprise, up to 75% of women have received more than one false diagnosis before the accurate management is delivered to them. They're probably being treated as food poisoning or AGE, PID, irritable bowel syndrome, or even UTI. Some were just being treated as primary dysmenorrhea without obvious pelvic cause, especially when they presented at the early young adolescent. The delay in diagnosis got worsened as the current practice, which rely primarily on laparoscopy for a definitive diagnosis before beginning therapy. Do we really need laparoscopy to confirm the diagnosis? The answer is probably no. This is the algorithm for the critical diagnosis of endometriosis. We evaluate the symptom, review the patient history, perform physical examination, and finally supported by some investigation. What should you ask? We look for symptoms that are suggestive for endometriosis, for example, dysmenorrhea, deep dysmenorrhea, patient history such as infertility, any previous laparoscopy with the diagnosis or treatments. We also knew that from physical examination, a presence of fixed retroverted uterus, mass consistent with endometrioma or adnexal mass, a thick uterosacral ligament, and sometimes the nodule felt at the POD area might suggest endometriosis. Endometrioma on ultrasound, a typical classical appearance of ground glass appearance, posterior shadowing. Sometimes we do see a nodule and mass as the POD that suggests DIE, and of course the blood test CA125 to see the disease activity. Remember the slide I showed you earlier? 3 types of endometriosis. Here we can see a presence of ovarian cyst or endometrioma or chocolate cyst. And what happened here, because of the adhesions, the presence of bilateral cysts and the cysts stuck to each other and form a kissing ovarian cyst. For your level before enter the Part 2 MOG exam, you should make the attempt to look for evidence of severe disease. This is probably a good paper for you to study more ultrasound imaging for severe disease. Look for sliding sign, kissing sign, and what we call that moves endless sign, a sign of deep infiltrating endometriosis. If you found this image, then you should always suspect malignant change. The risk is probably between 0.7 to 1%, presence of solid cystic area, septation, multiloculated, papillary projection, bilaterality, size more than 5 cm, increased vascularity, ascites, or mental cakes are all suggestive of malignant changes in endometriosis. Are all women require diagnostic laparoscopy? Answer is probably no at the initial assessment. Women come to us with complaints of dysmenorrhea. A trial of 3 to 6 months of simple analgesia or hormonal preparation can be given to them. If empirical treatment fail, or there is a need to revise the diagnosis, or any other pathology is suspected, or even in the parts of fertility workup, example, checking the patency of both tubes, or you suspect malignancy, stage the disease. Some therapeutic also can be done, for example, removing the cyst, eviscerations, trying to reduce to prevent the recurrence and to improve patient symptoms as, of course, the fertility outcome. I hope that you agree with me, endometriosis should be viewed as a chronic disease that requires a lifelong management plan with the goal of maximize the use of medical treatments, avoid repeating surgical procedure. I will focus on the management of endometriosis-related pain, as endometriosis with subfertility will be covered by Professor Dr. Mokri on Wednesday. First question probably asked, is any fertility concern when patient came to you? If no, then you can always start the umbilical treatments for 3 to 6 months that I mentioned earlier. Either progestin or combined OCP can be used. GnRH analog is another option in selected patients. And again, do Madam T need a diagnostic laparoscopy to confirm endometriosis before starting treatment? The answer is no. What we have for medical therapy, all available drugs are not curative. It aims to reduce the symptom, to reduce recurrence, and improve quality of life. Various therapy has almost similar efficacy, to be honest with you, but with different side effect profile. Choice of drug depends on safety, tolerability, and cost. Rarely we use danazol or gestrinone now, a very old drugs. So again, what group of patients might consider for surgery? Surgical management encompasses conservative and definitive procedure. Surgical management is indicated in patients with pelvic pain who have not responded to medical therapy, patients who have declined medical therapy or have contraindication to medical therapy, Symptomatic patient with confirmed or suspected ovarian endometrioma of more than 3 cm, or during the follow-up or serial ultrasound scan showing increasing volumes of endometrioma, patient with functional organ damage, for example, intestinal obstructions or urinary tract impairments, especially when the linear function is involved. So if you're gonna go in for small endometrioma, especially in a younger woman who still desire for fertility, our surgery might further jeopardize the ovarian reserve. Of course, certain good surgical techniques can be used to minimize the effect of ovarian reserve, such as minimal use of electrocautery device, use of water dissection, gentle handling of the tissue, avoid dichotomy of the apex, the blood supply area, secure the hemostasis to prevent future adhesion, especially on the tube. Thus, even with patients of small endometrioma, we can actually go for medical therapy with Pathogenesis. Preservation of ovarian reserve is observed from the study after 6 months of Pathogenesis 2 mg daily. We can see here there's improvement in antral follicle count and there's no significant change in anti-mullerian hormones level from the baseline. So even for surgical excisions of endometrioma, the risk of recurrence is between 7 to 30%. That also depends on how perfect you perform the surgery. If you go in for diagnostic laparoscopy, aspiration, and biopsy, I can ascertain you that the risk of recurrence is almost 100%. So generally, the size of endometrioma 5 cm to be considered for surgery. Of course, some people use 3 cm. And what happened to Madam T? Madam T was given NSAIDs for 3 months, then changed to combined OCP for 6 months. The pain got worsened and ultrasound showed 6 × 6 cm multilocular cyst with ground-glass appearance. She underwent diagnostic laparoscopy and avisation of endometrioma. Post-operatively, she was diagnosed to have stage 3 endometriosis with endometrioma. What happened if the cyst is small? In this prospective study, included 81 patients with ovarian endometriosis. 40 were treated with Pathogenesis 2 mg and another 41 treated with Pathogenesis plus 18 estradiol 30 micrograms daily. Aim of the study is to see the effects of the treatments on the size of the endometriotic cyst. The size of the endometrioma cyst was significantly reduced in the Pathogenesis group. You can see here the mean cyst diameter was 52 mm at the baseline and reduced to 32 mm after 6 months of Pathogenesis. This gives you a 75% volume reduction in the Pathogenesis group. Another important part of management now is to use the post-operative medical suppression therapy if patient underwent surgery. Without the use of post-op medical suppression therapy, the recurrence in 5 years is up to 50%. We must tell our patients spend some time in counseling that they need to be on hormone until they're keen to conceive or they have reached menopause. Often we ask this question, which one to go? Combine OCP or progestin? Either one can be used, or is one better than another? This is an important graph. We see here the estradiol level regards to bone loss and growth of endometrial lesion. Lower estradiol level induces bone loss, but higher estradiol level stimulates endometrial growth. The balance in this is to achieve a therapeutic window while keeping endometrial lesion atrophy, but without causing the significant bone loss. Thus, administering a high dose of estrogen and progestin in a combined OCP is counterproductive, resulting in estrogen dominance in the presence of progesterone resistance in the endometriosis. We knew that oral progestin has demonstrated a benefit in reducing pain and suppressing the anatomic extent of endometriotic lesions and can be used at any age. Do not increase the risk of thrombosis and with very, very minimal side effects. For example, irregular bleeding and some weight gain. We can see more clearly here the difference between combined OCP and progestin. In the combined OCP, it delivers a higher than physiological dose of estrogen. The EE dose in the lower dose USP is equal balance to 4 to 6-fold the physiological estrogen level. Supraphysiological concentration of estrogen may rescue endometrial cells cluster deposited in the pelvis during retrograde menses and stimulate the disease. Whereas in progestin only pill, you can use at any age do not increase the risk of thrombosis. It can inhibit ovulation and induce relatively hypoestrogenic states that could help suppress the endometriosis and also induce amenorrhea with very few side effects. Having said that, not all progestin are the same. All preparations have different properties and side effect profile. We see here, Dynogest probably show a better property with anti-androgenic effects without other unwanted side effects as compared to other progestin. How about the use of generation analog versus Dynogest? We can see here in this systematic review, Dynogest 2 mg per day was superior to placebo in reducing pelvic pain with similar results to generation analog. Both reduced endometriotic lesion and improvement in pelvic pain. Just the case that generation analog has limited to 6 months or maximum 1 year for the treatment duration. Another study showed that both generation analog and Dynogest are equally effective, 40% pain-free in the first 4 weeks after the use. By week 24, both treatment with generation analog and Dynogest show 53% women are free from pelvic symptoms, no woman reported severe dysmenorrhea, and 70% of women are free from dyspareunia. So as mentioned earlier, generation analog was limited to duration treatment of 6 months or up to 1 year. So looking at this graph, the recurrent rates of 50% at 5 years, the patient need long-term medical suppression therapy. So either you can use generation analog for first 6 months, followed by oral progestin until they wanted to conceive or until they reach menopause, or you can start straight away using progestin immediately after the surgery. Same data show that 40 to 50% recurrent rates of 5 years and 21% recurrent at 2 years. Of course, the recurrence of endometriosis symptom and pelvic pain is actually directly correlated to the surgical precision and removal of peritoneum and deeply infiltrating disease. Ask ourselves how many of us are like Dr. Salva from Makota Medical Center, who is so expert in laparoscopy surgery. Thus, the long-term administration of post-op medical therapy is crucial here. Patients might think that they are asymptomatic and free for the disease and defaulted your treatment or follow-up. This study shows that with the treatments of Dynogest for 5 years, the risk of endometrial recurrence is reduced significantly. So we see here, the cumulative recurrence rate is significantly reduced as compared to those without post-operative medical therapy, and the reoperation rates also reduced significantly with the long-term medical suppression therapy after the surgery. Another study with long-term use of Dynogest in endometriosis pain was assessed, and the pain was significantly improved. Mild side effects of Dynogest were treated and addressed easily with the use of Dynogest. Not only that, improvement from clinical symptoms, we see here the endometriotic lesions also improve with 6-month treatments with Dynogest. But you might question whether or not this is translated into any significant clinically, as we know that the staging of endometriosis does not correlate with any clinical. The patient can have mild disease but severe pain, and severe disease but without any pain. Thus, lastly, maintain long-term therapy is a crucial point here. Again, we stick to our goals here when dealing with endometriosis. The goals in the long-term management of pelvic endometriosis is to suppress the pain, preserve the fertility, prevent recurrence, maintain treatment adherence, avoid bone loss, and of course, lastly, improve the quality of life. Of course, all treatment came with side effects. This includes Dynogest. The progesterogenic side effects, which includes breast discomfort, nausea, and irritability, are mild, transient, and easily managed. We also see that the bleeding irregularity is one of the downsides for any progestin. But if this is counseled and explained to all patients before they started with the treatment who suffer from severe pain for endometriosis, I'm pretty sure that they can accept this minor side effect. And we also see that the bleeding pattern improves with time. So what we want here for patients with endometriosis that concerned with pain, we made the early diagnosis and started the medical therapy for pain. So once the medical therapy started, we try to avoid surgery unless they are not responsive to the medical therapy. And after the surgery, we continue the post-op medical therapy to prevent the recurrence. Unless the patient comes with the pain and some occlusive or obstructive symptoms such as intestinal obstructions, then you have no choice to go in for surgery. Again, medical therapy to prevent the future recurrence. How about those claiming with pain and infertility issue? Of course, once the diagnosis is made, medical therapy for the pain, we encourage them to conceive pregnant and conceive earlier after delivery, followed by medical therapy again until they want to conceive again or they reach menopause. How about those with fertility issue? After the medical therapy for pain, they will be undergone surgery or ALT for the fertility. Maybe both Mukli can explain more about these parts of the treatments. Then after that, again, medical therapy to prevent future recurrence. So what happened to Madam T? She's 42-year-old now, Palawan. She underwent one diagnostic laparoscopy evisceration. We started her on generation lock for 6 months, followed by Diagnosis. She's pregnant by IVF, but she defaulted treatment for the last 3 years. Now she's asymptomatic, but ultrasound noted a recurrent endometrioma of 8x7 cm. What is your plan? If I can conclude my presentation here, endometriosis is a chronic, devastating disease and management is challenging. Management aims to elevate the symptom, maintain and restore fertility, avoid recurrence and improve quality of life. Treatments must be individualized. Maximize medical options and surgery reserved for those who need it and preferably again the only one and last surgery for them. On behalf of Malaysian Menopause Society and UKM, I'm inviting all of you to attend our Women's Health National Webinar Roadshow on 9th of October 2021, Saturday. It's a FOC event. We have 10 series of talk regarding women's health. So please join us on 9th of October. So these are the few speakers here that talking and sharing to us all the aspect of women's health. Yeah, with that, thank you so much for your attention. I'm happy to take any question from you guys. Thank you so much again to join us in this MOG course and your support. Thank you so much.
Right, Prof, we have 3 questions in the chat box. The first question, how long may a woman continuously use the Dynogest? It is also contraceptive.
Thank you for the questions. We know that the longest study that so far involving Dynogest is up to 5 years. So in the 5 years time, Dynogest is very helpful in terms of reducing the endometriosis-related pelvic pain, as well as few minimal side effects that are identified and easily treated and managed. So the study is up to 5 years now, is safe. Now we also know that the worries or concerns about the use of progestin is about the effect on the bone mineral density. So it happens to all the progestin, the effects of progestin towards the bone mineral density. So you have such concerns about bone mineral density effect, especially when you use it at the adolescent periods. Then what you can do is you can monitor them with the bone mineral density regularly. If you have worry and concerns about the effects on the bone mineral density, you can off it and stop temporarily. And then you can start back the Dynogest after that, after 3 months or 6 months. Dynogest never indicated as contraception. We know that patients with endometriosis, they got problems or issue with the infertility already. So when they use Dynogest, okay, Dynogest is to treat their endometriosis problem, but Dynogest cannot prevent them from getting pregnant. But from the experience, we know that with the use of Dynogest on top of endometriosis, hardly they get pregnant.
For the second question, as it is a chronic disease, need lifelong medical treatment, and Dynogest is limited to only 5 years. Hence, what is the best medical treatment till they reach a menopause?
Okay, I never say that it's only reach 5 years, you should stop it. Okay, so if there's no effects on the bone mineral density, you can actually continue more than 5 years. There's no issue. Only then, when you got concerns about the bone mineral density, then you should stop and treat the osteopenia or osteoporosis. If it happens, then you can restart back again. So if you have such concerns after the 5 years, then you can continue with the combined OCP. We know that combined OCP is not or never indicated to be used as treatment for endometriosis. It's an off-label use. But COCP can be used in the alternative to the Dynogest. So in this case, I'll prefer, if there's no bone mineral density problem, then I'll continue use of Dynogest. If you've got suspicious of effects of the bone mineral density, treat that osteopenia or osteoporosis and come back again, or change to COCP.
Okay.
So it's important now, Rowaida, to actually explain to patients regarding the use of lifelong medical suppression therapy. If not, that tends to come back again later with the recurrent. It happens to so many patients. I'm sure you have this experience as well. They thought they are free of symptoms. The endometriotic lesion might be growing in the pelvis, but they are asymptomatic. We know that, right? In my slide, I mentioned that one of the problems with endometriosis is the staging or the disease severity does not correlate clinically. So some patients think that they are free of symptoms, but actually they got problem. The pelvic endometriotic lesion is growing inside. So when they come again without the hormones, then they tend to get the recurrent, and that is a reason, or that is another indication for you to go in for surgery. You definitely don't want to operate multiple times in patient endometriosis. I'm sure that we see frozen pelvis before that. Sometimes we need to open and close.
So there's another 2 questions, Prof. Can deep infiltrative endometriosis diagnosed by clinically or TVS or MRI alone rather than laparoscopic? If yes, is the medical management adequate to treat it?
Yeah, that's a very good question. Okay. We know that we always diagnose endometriosis clinically by history and examination. I mentioned inside the slides, history typically pain, dysmenorrhea, dyspareunia, and subfertility. Of course, the physical finding typically suggests of endometriosis is your fixed retroverted uterus with anisal mass, right? Nodularity and thickened uterosacral ligament. From these 2 aspects, then you can roughly guess that this is probably endometriosis. Endometriosis, you can start your umbilical treatment 3 to 6 months before you need to go for diagnostic laparoscopy. So diagnostic laparoscopy is not a must at the initial assessment and management. After 3 to 6 months of treatments, umbilical treatments with your painkiller or hormonal preparation, and the patient still persisted with pain, only then you need to revise your diagnosis. Either you want to go in for diagnostic laparoscopy. Of course, when you suspect a deep infiltrating endometriosis, you know that using the transvaginal scan sometimes can be difficult. The sign that I show you in the slide, right? How often that we do that, right? But the sliding sign is very important and easily performed. Then you can diagnose there is an adhesions and probably deep infiltrating endometriosis. To see a lesion at the POD using vaginal scan, and you really need to be more skillful. So in this case, if there's clinical suspicion of deep infiltrating endometriosis and you wanted to go in for surgery to remove the DIE, then of course MRI will be very, very helpful. So can you diagnose DIE with radiological imaging with ultrasound MRI? The answer is yes. Do we need to go in for surgery? The answer is not necessarily. You still can try medical therapy, for example, the use of generation lock or Dynogest. If this medical therapy is failed, only then you have no choice to go in to remove the DIE. And this is a bit challenging that we know, right?
For the last question, Prof, for the last clinical scenario of the Madam T, any role of Dynogest in huge endometrioma more than 5 cm, will it help in reduction of size by 75% too?
Oh, that is a question I posed to you. I thought I want to ask you to answer in the chat box. Then while waiting for my second thought, I see what is your answer. Okay, of course, to discuss the Madam T scenario at 41-year-old now with the endometrioma more than 5 cm asymptomatic, options that included in your exam discussion or in real life discussion would be: one, conservative management. You do not need to do anything, but unlikely you will offer or you will go approach with this conservative management without doing anything. Then you know that she probably will suffer from symptom later, or the endometrioma will getting bigger, and in fact sometimes it can have other surgical complications, for example intestinal obstructions or GU tract obstructions. Okay, so second option will be medical. Medical here, of course, urination log or Dynogest. Okay, can the Dynogest reduce the size more than 75%, like mentioned by this participant? Okay, anything less than 5 cm, then from my experience, yes. More than 5 cm, the sorry to bear, I'm sure they are in here. I seldom see such a huge reduction with the use of Dynogest more than 5 cm. So in this case, if you want to go in for surgery, then during the surgery, you have few more options. You see in your exams, right, when you go for the holistic approach, right, you should think of all various options. So during the surgery, you have 3 options that I can think of. One, laparoscopic evisceration, you just remove the cyst, then with a chance of recurrence. Second, you can go for unilateral salpingo-oophorectomy. Okay, in this case, you can remove the whole ovary that involved in one side. This will definitely help to reduce the recurrence at that site. Okay, not to forget the malignant changes in endometrioma that quoted around 0.7 to 1%. Okay, third option will be surgical capsule. You remove the whole thing, but the patient need to be on hormone replacement therapy. So in view of she's 41 years old only, maybe unilateral salpingo-oophorectomy will be the better option here. Okay, so where I use medical therapy, it is an option, but I'll prefer the surgery in this case.
All right, thank you very much, Prof. It's a very interesting talk. So now we shall move on to our second lunch symposium entitled Beyond Atrophic Vaginitis, A Little Goes a Long Way, by Prof. also.
Thank you, Ruwaida.
Thank you.
Very good afternoon, everyone. Dr. Ng here from UK Medical Center. Today, I'm going to share with you Beyond Atrophic Vaginitis, A Little Goes a Long Way, or we call that genitourinary syndromes of menopause. I have no conflict or interest except receiving some speaker honorarium for today's educational talk. Genitourinary syndromes of menopause describe the symptom and signs resulting from the effects of estrogen deficiency on the female genital urinary tract. As we know, prevalence of GSM is getting higher since years of menopause. Unlike vasomotor symptoms tends to disappear after a few years of last periods, genital urinary symptoms tend to get worse and worse, and 80% of them have this GSM after 10 years of menopause. As you can see, 50% of them are symptomatic. Thus, early diagnosis and treatment should be implemented before irreversible changes have been taken place. Life expectancy of women have reached 77 years old as compared to male 72 years old. As the natural menopause occurs at around 51 years old, like it or not, 1/3 of your lifespan will be at the post-menopause period. For many women tend to worry about vasomotor symptoms that come on with the change during the menopause. The long-term effects of menopause are more alarming. Early menopause symptoms include night sweats, unable to sleep, anxiety, mood swing, depressive symptoms, and reduced sexual function. Few years later, they started experiencing genital urinary symptoms such as vaginal atrophy, dryness, and painful sexual intercourse. This is now termed genital urinary syndrome of menopause. Later, women might suffer from heart disease, osteoporosis, and even Alzheimer's. Despite the high prevalence of vaginal symptoms, women may be reluctant to visit their doctor or to discuss this symptom, and sadly, clinicians also rarely screen for such concern. An earlier study showed that only 30% of doctors asking vaginal symptoms when the patient came for any gynae visits. The Viva Vaginal Health Insights Views and Attitudes quantitative online survey had conducted in North America to explore the women's knowledge about menopause its symptom, awareness, perceptions, and treatment experience. This included 3,520 postmenopausal women between age of 55 and 65 years old. Most women perceive being healthy, good quality of life, and being fit as important factor to achieve happiness. We can see here, only half of the women think that sexual intimacy is an important factor. In women who had experienced vaginal discomfort, the most common symptoms were vaginal dryness, 85%, and pain during sexual intercourse, 52%. One-third of them complaining of perineal itchiness and urinary incontinence. Some other symptoms include soreness, burning, and pain. When asked about source of information they had used or would consider using to find out about vaginal discomfort, 80% of them choose a healthcare professional and 52% were checked on the website. Only 41% women believe enough information about vaginal symptoms to be available. 79% aware that some forms of treatment available for vaginal discomfort. 73% aware of non-hormonal treatment, and only 65% being aware of hormonal preparations for their vaginal symptom. How about the impact on quality of life? 80% of them think that there were negative effects on their life. 75% of them thought there will be adverse effects on their sexual intimacy. 68% of them feel like they are less sexual now. 36% of them think they are getting old. And of course, one-third of them thought that there were negative consequences on their marriage or relationship. And 26% thought that there will be negative effect on their self-esteem. And 1/4 of them thought their quality of life will be lower when they have this vaginal symptom. You can see here the effect on quality of life not only physically but also mentally. Menopausal women suffer silently, especially regards to sexual dysfunction and GSM. Another survey among 3,046 US women reported GSM symptoms in this Levi study. 85% of them have lost their intimacy. 47% thinks that their relationship have been interfered and affect their sleep in 30% of patients. Vulvar vaginal atrophy was a commonly used term in the past to describe the genitourinary changes of menopause. It has limitations. Vulvar vaginal atrophy describes the appearance of the genital tissue, but not the associated symptom. It does not include urinary tract changes related to estrogen deficiency, and the term atrophy has negative association for the woman. Thus, the new term genitourinary syndrome or menopause (GSM) has been started to be used. This includes the symptoms and signs resulting from the effects of estrogen deficiency on the female genitourinary tracts, including the vagina, labia, urethra, and bladder. This syndrome includes genital symptoms of dryness, burning, and irritation, urinary symptoms and conditions of dysuria, urgency, and recurrent urinary tract infections, as well as sexual symptoms of pain and dryness. For those that are preparing for the exams, these are probably the anatomy and physiological changes that happens in the genital area. The genital and lower urinary tract share a common embryologic origin in women, with the urethra, bladder trigons, vulvar vestibule, and the upper vagina all are derived from the same estrogen receptor-rich primitive urogenital sinus tissue. During this GVDSM, there will be diminished estrogen level and aging were found to be independent factors in decreasing the vaginal cervical paracellular permeability, a change that potentially related to vaginal dryness. After menopause, women are also less likely to have a lactobacillus dominant vaginal bacterial community and likely to have a low vaginal pH and recurrent vaginal infections. Estrogen deficiency is associated with vaginal atrophy. We want a very healthy vaginal epithelium which consists of superficial cells, intermediate cells, and parabasal cells, so that this will contribute to overall defense mechanism to prevent vaginal infections as well as vaginal atrophy. So when estrogen level is low in the perimenopause or postmenopause lady, they tend to have all these bacterial vaginosis and other forms of vaginal infections. These are some of the typical physical findings in patients with GSM. There be reduced mons pubis and labia majora bulbs. The labia is atrophy, vaginal dryness, introitus stenosis, clitoral atrophy, and there might be some erythema of the urethra meatus or presence of urethral caruncle. The vagina mucosa is moved now. There will be loss of lubrications. It looks shiny and dry. The cervix flush with vagina, and vaginal discharge is common in this time. When we come to the severe